welcome to Chapter 12. Here we will discuss pain management. This starts in your text on page 212. When we talk about pain management, we first want to understand what pain is. And some of you may have heard that pain is now the fifth vital sign. So this is an important thing to ask your patients every time you go in to assess them. You want to make yourself familiar with the terms also located in your text on page 212 and 213. First, we will look at some fundamental concepts. Of course, like I said, make sure you know that definition of pain, and then we'll look at the effects of pain. Pain affects individuals of every age, sex, race, and socioeconomic class. It does not discriminate, and we have to distinguish most times between if a patient is in pain or a patient is pain seeking. This is always the controversy and goes into some legal and ethical issues, which we will talk about shortly. When we look at the types and categories of pain, there are many ways to categorize pain, and clear distinctions are not always possible. Pain often is described as being both acute or chronic. Remember what acute and chronic is from before. Your acute pain differs from that of your chronic pain primarily in its duration. Remember, just like when we talked about chronic diseases and disorders, they're anything that lasts longer than 3 months. And this goes the same for your pain. For example, some patients with cancer have continuous chronic pain and also experience acute exacerbations of pain periodically called breakthrough pain. And you will learn that there are also breakthrough medications for pain that your provider may prescribe for patients when they have these exacerbations. So remember, pain is what the person says it is. A lot of times, we as healthcare providers may not think the patient is in pain, but they may be rating their pain on a scale of 8 from that scale of 1 to 10, but they're laughing and joking and talking with their friends. We still have to take their word for whatever they say their pain is. Make sure also that your patients understand the physiology of pain and how it is associated with their disease or disorder or any procedure may have. Also, if they do speak a different language, try using a scale that is in their language, if at all possible. But you also want to make sure that you have the English interpretation for yourself as well. You do not want to give a patient a pain scale that is, let's say, Chinese, and you don't understand it, and they're pointing to something that may be a rate of 3 on a scale of 1 to 10, but you don't have it in English, so you have no clue what they're pointing at. So make sure if you do have scales in different languages, and I know that some healthcare facilities do, make sure that it has that English interpretation on the other side so that you can receive the patient's message correctly. When we look at that pathophysiology of pain, we want to first look at how pain is classified. And it is better classified by its inferred pathology as being either nociceptive pain or neuropathic pain. So when we look at the nociceptive or the physiologic pain, this refers to the normal functioning of physiologic systems that leads to the perception of noxious stimuli, which is that tissue injury, as being painful. Another example is like a burn. That would be your tissue injury that would cause that noxious stimuli. This is why nociception is described as normal pain transmission. When we look at neuropathic or the pathophysiologic pain, this is pathologic and results from abnormal processing of sensory input by the nervous system as a result of damage to the peripheral or central nervous system, or both. Patients may have a combination of nociceptive and neuropathic pain. Look at the example in your text. A patient may have nociceptive pain as a result of a tumor growth and also report radiating sharp and shooting neuropathic pain if the tumor is pressing against a nerve plexus. So you can see the difference between the two. Also looking at nociceptive pain, this includes 4 specific processes: transduction, transmission, perception, and modulation. The most important one that I do want you guys to know is transduction. And your transduction refers to the process by which noxious stimuli, such as a surgical incision or a burn, activate primary afferent neurons called nociceptors. These are located throughout the body in the skin, subcutaneous tissue, and the visceral organ or somatic, which is your musculoskeletal structures. Prostaglandins are lipid compounds that innate inflammatory responses that increase tissue swelling and pain at the site of injury. Transmission is another one of those processes, and that is the second process that is involved. But the most important one that I do want you guys to know is transduction. Please do review what the other 3 are, being your transmission, perception, and modulation. Another one that I do want to look at is the third process, which is your perception, and this is involved in nociception as well. It is the result of neural activity associated with the transmission of noxious stimuli. It requires activation of higher brain structures for occurrence of awareness, emotions, and drives associated with pain. The physiology of perception of pain continues to be studied, but can be targeted by mind-body therapies such as distraction and imagery, as well as meditation. These are based on the belief that the brain processes can strongly influence pain perception. So the main thing I wanted you to get from that one is that these can be targeted by the mind-body therapies, such as your distraction and imagery, pretty much fooling the brain into thinking that the pain is not there, or taking the brain elsewhere so that that patient is not in such agonizing pain. And some people like to use this in place of medicine or before medications or pharmacologic therapy is instituted. I also want you guys to look at Table 12-2. It goes over the classification of pain by inferred pathology. So it goes over your physiologic processes. It goes over nociceptive pain versus neuropathic pain and then mixing them together. It also gives you some categories and examples, so do look at those, as well as your pharmacologic treatments. And we'll talk about the pharmacologic treatments in a few minutes. The last process is your modulation, and that's your 4th process with nociceptive pain. You just want to know that what it is and how it works, and they also give you some examples about serotonin and norepinephrine within your text. Here is a good illustration of the nociception system showing the ascending and descending pathways of the dorsal horn. There is very vivid and good explanatory illustrations in your text on page 216 that gives you a visual of each of those 4 processes in regards to nociception. A being transduction, B being transmission, C as perception, and D as modulation. So you do want to look at those kind of to give you that visual and connect from what you read to understand how it actually works in the brain. Here is the gate control system theory. And it just pretty much shows you from that dorsal horn how your pain receptors are going to your brain, the message, your placebo, if you are receiving any kind of spinal or local analgesic as far as pain relief. Any depression or anxiety, though it shows you plus or minuses. So it goes from ascending to descending. So you can use both illustrations to understand or grasp a better understanding of how these pain receptors work. Here's a true or false statement regarding endorphins. And the answer is false, and here's the rationale. And then we'll look at some factors that influence pain response. But before we look at those factors, I just want to briefly go over neuropathic pain since we covered nociception and those processes. When we look at neuropathic pain, it is sustained by mechanisms that are driven by damage to or dysfunction of the peripheral or central nervous system and is the result of abnormal processing of stimuli. Unlike nociceptive pain, neuropathic pain may occur in the absence of tissue damage and inflammation, even when acute neuropathic severs are no longer useful or they have no useful purpose. When we look at the peripheral mechanisms, at any point from the periphery to the CNS, the potential exists for the development of neuropathic pain. Hyperexcitable nerve endings in the periphery can become damaged, leading to abnormal reorganization of the nervous system called neuroplasticity. This is an underlying mechanism of some neuropathic pain states, and that is important to know. So here are some factors that do include or influence pain response. Of course, any past experience, and by past experience, they mean if you've had that injury prior and you have that injury again, let's say you fractured your left arm and it healed, but you had a bad experience with that, pain was uncontrollable, and then 5 years later you fractured that arm. So you may remember that past experience and your brain may signal that nothing's going to work or whatever pain medication you had last time would not work. Also, another thing is anxiety. If you're anxious, sometimes pain medications do not work, and we have to actually alleviate the anxiety before we give pain medication. Also, another influence is depression. Culture, age can be a factor, as well as gender. And when we look at age, we tend to think from one extreme to the other. So we either think very young, as in our infants and children, and the myth that they do not feel pain, versus your elderly people where you're thinking they don't know that they're in pain, or they may say that they're in more pain that they actually are in. So age can play a big factor, as well as gender. Some say, males do not want pain medication. They feel macho and they don't want to ask for pain med. Versus your females, the myth or a stereotype may be that they want a lot of pain meds because they can't bear pain. But one has to realize women birth children. So, there's not much more pain than that, pretty much. So we have to look at all of those factors that do influence those pain responses. Now, as nurses, we do to serve not only as the primary care providers, we want to serve as advocates, especially when it comes to having effective pain control and management. If you know the patient is not being controlled on their regimen, You want to serve as an advocate for that patient and say, hey, let me give you pain meds, or at least offer pain meds every 4 hours. You will also maybe serve as an educator, educating them that they do not want to let their pain tolerance get high. They want to take medication before their pain gets intolerable, because then it is easier to control if we medicate prior to the pain becoming, that god awful 10 out of 10. Here we look at the types of pain. And again, we talked about and distinguished between acute and chronic pain. There's cancer-related pain for those that are plagued with that disorder or disease of cancer. There's pain associated with that, and it may be classified by location or its cause. So we all want to make sure we know what the pain is being caused by, if it's from a surgery, if it's from, chemotherapy or radiation. We want to know how this pain is being manifested when we assess our patients. So remember it as your fifth vital sign. You're not just going in to do, blood pressure, respirations, temperature, pulse. You want to ask about pain each time as well. And one quick safety and quality nursing alert that is in your TED page 218 is that we as healthcare professionals do not have the right to deprive any patient of appropriate assessment and treatment simply because they believe a patient is not being truthful. Like the first slide said, we have to go with what the patient says their pain is. We cannot deprive them medications because we think they're not in pain. We have to go with what they decide that the pain level is at that time. Here are some more pain-related syndromes. And most of these you may have heard of, and some of them you may have never heard of, and we'll talk about within this course. Complex regional pain syndrome, you may or may not have heard of. Post-mastectomy pain syndrome, of course, that's after your women have their breast removed, usually for breast cancer. Fibromyalgia, that is a chronic pain syndrome as well. Hemiplegia associated with shoulder pain that is associated with sickle cell disease is also very common. And the patient that you may see in the hospital setting for this may come in with sickle cell crisis, which they are in pain as well. Of course, you have your AIDS-related pain, burns, of course, those always are painful, your Guillain-Barré syndrome pain, and then, of course, opioid tolerance. And I know that sounds kind of odd that it may be a pain syndrome, but if the patient has a prior injury or a past experience where, let's say, they herniated a disc in their lumbar section and they've been on Percocet for the last 6 or 7 years, if they were ever to get off of that Percocet, they would have pain again. Even if, it healed, they had a fusion, and the injury actually healed, they, in their mind, are tolerant, or even, they may even be considered dependent on that Percocet for them to be pain-free and able to function on a daily basis. And so we'll go more into that when we talk about those pharmacologic therapies. Now, looking at the effects of pain, of course, if a person is in pain, they may not be able to sleep. That is one common thing that patients complain of if they are in pain. They are not able to rest. Your acute pain can affect the respiratory, cardiovascular, endocrine, and immune systems. Stress response increases metabolic rate, cardiac output, and the risk for physiologic disorders. So we do want to get that pain under control, especially your acute pain that isn't going to last. Usually we put these patients on a scheduled pain medication or even a PRN, but at the same token, we have to educate these patients about their PRN or medications that are given as needed. Because if they're not asking for the medications and they're waiting again until the pain is, let's say, an 8, 9, or 10 out of 10, then we are not controlling their pain adequately. Because first, you want to educate your patients that if you're giving them PO medications for pain, that they usually take about 30 to 45 minutes to work before they'll start. And so if your pain is at a 10, you certainly do not want to wait for 45 minutes before your medication can kick in. So we usually tell patients, when you start feeling the pain, if it's at a 3 or 2 or 3, let us know that we can medicate you, and we can keep that pain level below a 2 and not at a 7 at all times. So that's just some education that you want to make sure your patients are aware of. Looking at the effects of pain and looking at chronic pain, that's for your disabilities and disorders and injuries that will cause pain to last longer than that 3-month period. This can cause the patient to be depressed, have an increased disability, depending on what is actually hurting. Is it debilitating to them? And a suppression of the immune function. So we want to also keep these patients on some type of regimen, especially if they're prone to have acute exacerbations. So it just depends on the disorder or disease or surgical procedure that they have that will cause them to have that chronic pain or that acute pain, and what type of medication we would put them on. And here's a question in regards to the time frame with pain being classified as chronic. And here's the answer with the rationale. And your answer says longer than 6 months, and that is true. I don't want you to be confused. I know I've been saying 3 months. Usually after that 3 to 4 month mark, we consider it chronic, just because if they have a chronic disease, and that's going to be past 3 months. If it's associated with any pain, then we're going to pretty much tell them they're going to have chronic pain. For most of your acute surgical procedures and things of that nature, usually all of that pain is acute, so it's not going to last, longer than 6 months. So just classification on that. If you do see it again on your exam, I do not want you to be confused and put 3 months, although I've been saying 3 months. Your chronic pain, specifically talking about pain, if it is considered chronic, we'll say longer than 6 months. And here's the nociception process that we went over. It's in your text, and it's illustrated on page 216. And that just goes over those 4 processes: transduction, transmission, perception, and modulation. And this talks about the neuropathic pain and gives you an illustration of that. And that is also found in your text on page 217. Here we will look at the characteristics of pain, and this is usually done within your assessment. So when we look at your pain assessment, the highly subjective nature of pain causes challenges in the assessment and management. However, the patient's self-report is the undisputed standard for assessing the existence of pain. Clinicians, being us, or healthcare providers, are entitled to their personal doubts and opinions, but those doubts and opinions cannot be allowed to interfere with appropriate patient care. In your text, chart 12-1 on page 218 goes over strategies to use when the patient's report of pain is not accepted. So when performing the comprehensive pain assessment, of course we want to look at the location of pain. Ask the patient to state or point to the area of pain on the body. Sometimes allowing patients to make marks on the body diagram is also helpful in gaining this information, especially if they have a disability or a disorder that does not allow them to speak with you. You also want to ask them the intensity. Ask them to rate the severity of the pain using a reliable and valid pain assessment tool. And chart 12-2 in your text goes over educating patients and their families how to use a pain rating scale. Of course, you want to explain what it is and how it works, explain the parts of pain rating. If the patient does not like it or understand it, you want to switch to another scale. So there are numerous scales that are available. The one that we most often use is the FACES, which is in your text as figure 12-4. And sometimes they'll combine it with the NRS or the numeric rating scale and the FACES. So your numeric rating scale is the most often presented as a horizontal 0 to 10 point scale, with 10 being the worst and 0 being no pain at all. In the middle, of course, is your moderate pain. With your FACES scale, this consists of 6 faces with word descriptions ranging from smiling face on the left to no pain at all. Well, the smiling face means no pain or that the patient is not hurting, to a frowning face with tears, which means the patient is in severe pain. The faces are most commonly numbered using 0, 2, 4, 6, 8, and 10, although 0 to 5 can be used as well. The patient is, of course, asked to choose which face best represents them, and it is used in adults and children as young as 3 age. They have to know what the sign actually means before they can tell you how they feel. So usually you'll see that, and most healthcare facilities have it posted in the patient's room. They'll have the 0 to 10 scale as well as the faces in case they interchange their rooms with both pediatric and adults. So you may ask the adult, say they're 25, what's your pain on a scale of 1 to 10? They'll say a 5, versus your 8-year-old, you may say which face represents you. And if they say, none of those, say, okay, how is your pain on a scale of 0 to 10, with 0 being none and 10 being the worst pain you've ever had in your entire life? So you just have to do what works for the patient. And again, like I said, if the patient does not speak any English or does not understand the scale that you are currently using, then try to find a scale as far as pain goes that is or will work for that patient. And oftentimes they have pain scales that are in languages, which works out very well. So you also want to look at the quality. Ask the patient to describe how the pain feels. Descriptors can range from sharp or shooting, burning, gnawing, pinching, things like that. You want to ask about the onset and duration. Ask them when the pain started and whether it is constant or if it's intermittent. It may go and come depending on what's going on. You want to ask about aggravating and relieving factors. Ask the patient what makes the pain worse and, of course, what makes it better. And then you want to ask effect of pain on the function of quality of life. The effect of pain on the ability to perform recovery activities should be regularly evaluated in the patient with acute pain. It is particularly important to ask patients with persistent pain about how pain has affected their lives. What could do before the pain began that they can no longer do, or what they would like to do but cannot do because of the pain. And then, of course, a comfort function or pain intensity goal. Usually we get these on admission to pretty much see what the patient's pain tolerance is. For patients with acute pain, you want to identify those short-term functional goals and reinforce the patient that good pain control will more likely lead to successful achievement of the goals. Any other information that is pertinent for pain, the patient's culture, you want to consider that. Past pain experiences, any pertinent medical history such as comorbidities, laboratory testing, diagnostic studies, and those are all important in establishing that treatment plan. Now, for your patients who are unable to report their pain, these are the patients that are at higher risk for undertreated pain than those who can actually report it. In the population, this will include patients who are cognitively impaired, critically ill, meaning intubated or unresponsive, comatose, or imminently dying. Those patients who are receiving muscular blocking agents or are sedated from anesthesia and other drugs given during surgery are also at high risk. And that is just because we may not be assessing them as often, or in turn, we may be assessing them quite often, but we're not asking them about pain because of the simple fact that we're thinking as healthcare providers, oh, well, they've had anesthesia, so they're fine. Not so much. We want to stay on top of that pain medication so that they are not in intense pain. We do not want them to reach that 10 out of 10 at any time. I also want you guys to look at chart 12-3 in your text on page 220 that goes over the hierarchy of pain measures. Here are some pain intensity scales. You can go from a simple descriptive pain intensity scale. There's your numeric from 0 to 10, or they have a visual, and you could just point or draw a line depending on which one the patient interprets best. So you want to do what works best for your patient. And here's a question in regards to describing the quality of pain. And here's the rationale and the answer. And now we'll look at some physiologic basics for pain relief, including those pharmacologic interventions. Before we talk about that, I do want to look at how you would reassess your pain before we get into the actual pain management. and talking about pharmacologic versus or non-pharmacologic. Following initiation of any pain management plan, pain is reassessed and documented on a regular basis to evaluate the effectiveness of treatment. At a minimum, pain should be reassessed with each new report of pain and before or after the administration of analgesic agents. The frequency of reassessment depends on the stability of the patient's pain and is guided by the institutional policies. So, an example of that is if you assessed your patient at 8 a.m. for pain and they rated it at a 2 but did not want any pain medications, what time do you think you would reassess? Most likely you would reassess in 4 hours, which would be your next assessment, unless you're in a high acuity area where you're assessing your patient hourly or every 2 hours. Then you would assess them every 4 hours for pain at a minimum. At a maximum, every 8, depending on the unit you're on, depending on the patient population that you're taking care of. But you do want to follow hospital policy in regards to that as well. And then, of course, you just want to err on the side of caution and use nursing judgment, use common sense. If think your patient's in pain, don't wait 6 hours before you go ask them if they're in pain again. If they're saying they're at a 2, but they're looking like they're at a 6, this may be a cultural thing. So you want to check on them more often than, every 4 to 6 hours. Probably go back in 2 hours and say, how's your pain doing? Are you still at a 2? Are you sure you don't want any medication? And that's not forcing anything on the patient. It's just making sure that you're staying on top of your patient as far as pain control and pain management goes. So when we look at pain management, achieving optimal pain relief is best viewed on a continuum, with the primary objective being to provide both effective and safe analgesia. The quality of pain control should be addressed whenever the patient care is passed from one clinician to another, such as at shift and or transfer to one clinical area or another. Optimal pain relief is the responsibility of every member of the healthcare team and begins with titration of the analgesic agent, followed by continued prompt assessment and analgesic agent administration during the course of care to safely achieve pain intensities that allow the patients to meet their functional goals with relatively ease. Although it may not always be possible to achieve a patient's pain intensity goal within a short period of time, the patient is in an area like PACU or the emergency department, this goal provides direction for ongoing analgesic care. So note that pain is a complex phenomenon involving multiple underlying mechanisms and as such requires more than one analgesic agent to manage it safely and effectively. The recommended approach for the treatment of all types of pain in all age groups is called multimodal analgesia. A multimodal regimen combines drugs with different underlying mechanisms, which allows lower doses of each of the drugs in the treatment plan, reducing the potential for each to produce adverse effects. Further multimodal analgesia can result in comparable or greater pain relief than can be achieved with any single analgesic agent. The oral route is the preferred route of analgesic administration and should be used whenever feasible because it is generally the least expensive, best tolerated, and easiest to administer. When the oral route is not possible, such as in patients who cannot swallow or those that are NPO or nauseated, other routes of administration are used. In the immediate post-operative period, the intravenous route is the first-line route of administration for analgesic delivery, and patients are transitioned to the oral route as tolerated. The rectal route of analgesia administration is the alternative route when oral or IV analgesic agents are not an option. The rectum allows passive diffusion of medications and absorption of the systemic circulation. This route of administration can be less expensive and does not involve the skill and expertise required of the parental route of administration. Drawbacks are that the drug absorption can be unreliable and depends on many factors, including the rectal tissue health and administration technique. Of course, it wouldn't be recommended if your patient had diarrhea either, or some kind of rectal malformation or disorder. Also note that the rectal route is contraindicated in patients who are neutropenic or thrombocytopenic because of potential rectal bleeding. And we'll talk more about your neutropenic and thrombocytopenic patients. They are at risk for not only bleeding, they're at risk for infections and all sorts of things. So we don't want to put them at a higher risk by doing something like that. Again, diarrhea, perianal abscesses or fistulas, and abdominal perineal resections are also relative contraindications for that rectal route. The topical route of administration is used for both acute and chronic pain. For example, your non-opioid diclofenac is available in patch and gel formulations for applications directly at the painful areas. Local anesthetic creams such as Imla cream, which is used more so for your pediatric population, or the lidocaine cream, can be applied directly over the injection site prior to a painful needle stick procedure. And this can also be done for your lumbar punctures. Also, the lidocaine patch 5% is often used for well-localized types of neuropathic pain, such as your post-therapeutic neuralgia. It is important to distinguish between topical and transdermal. So your topical goes right on the skin as far as the creams. Your transdermal usually goes underneath the skin. Usually we have, that's intradermal. Your transdermal are your patches. So be aware of the difference. Don't get confused by the three. So you have intradermal, which will go underneath your skin, and that's usually not a pain medication. That's usually only done for your PPD. Your transdermal are your patches, and then your topical are usually your creams. So that's the difference between those. Some of the more invasive methods used to manage pain are accomplished by catheter techniques such as your intraspinal, sometimes called your neuroaxial analgesia. And what I want you to look at is your intracatheter or intrathecal catheters for acute pain management are used most often for providing analgesia or a single bolus dose of an analgesic agent. Temporary epidural catheters for acute pain management are removed after 2 to 4 days. Epidural analgesia is administered by clinician-administered bolus, continuous infusion, which is a basal rate, and a patient-controlled epidural anesthesia, which is your PCEA. Common opioids administered intraspinally will be your morphine, fentanyl, and hydromorphone, or your Dilaudid. These are usually combined with a local anesthetic, most often ropivacaine or Naropin, or your bupivacaine or Marcaine. This is to improve analgesia and produce an opioid dose-sparing effect. A relatively new pain management technique that involves the use of an indwelling catheter is the continuous peripheral nerve block, also called your perineural anesthesia. So here we look at opioid tolerance and addiction, and you want to note that maximum safe opioid dosage must be individually assessed. So when we're looking at the dosing regimen, two basic principles of providing effective pain management are preventing pain and maintaining a pain intensity that allows the patient to accomplish functional or quality of life goals with relatively easy access. So we don't want them to have to force themselves or be in extreme amounts of pain when they're trying to perform activities of daily living. We want them to function normally. Accomplishment of these goals may require the mainstay analgesic agent to be administered on a scheduled, around the clock basis, also known as your ATC, rather than your PRN, which is your as needed, to maintain stable analgesic blood levels. Now, what they mean by around the clock, we're not saying give pain medications every hour. Usually, if they're on a PO, opioid analgesic agent, then that may be dosed every 4 hours. If it is IV, it may be dosed every 2 hours to every 6 hours. The hospitals are straying away from giving you that leeway to decipher which time period you want to give. Before, they used to write orders that said give every 4 to 6 hours. They've gone away from that because of the medications and how they were being given. Some nurses would give them every 4, some would give them every 6, and then the patient was getting too much of the medication within a 24-hour period. So now the orders are very straightforward. It says administer, let's say, IV morphine Q2 hours for pain. It may give you an order for ketorolac or Toradol that is also IV Q6 hours PRN for breakthrough. And they have to write what the indication is. So they can't just say morphine IV Q2 hours. Pharmacy is not going to release it until the physician or healthcare provider gives you an indication. So that's just an example of your around the clock. We are going to give that medication every 4 hours or however it is dosed. If it's every 4 hours, if it's 6 hours, we're going to give it at that time. Now, the patient does have the right to refuse, but we are going to go in and offer it every 6 hours. They do not have to take it every 6 hours, but that is better than them not taking it at all and us not offering it until they ask for it, because we know that patients sometimes wait until their pain is at a 6 or 8 before they ask for anything. So that is what your text is referring to as far as around the clock goes. Your PRN, of course, are your same drug orders, but it says it may say morphine, IV, Q2 hours, PRN for pain. So then at that 2 hour mark, your patient doesn't want it. Well, are you going to check in another 2 hours? You're saying your patient doesn't want it, but your patient hasn't wanted pain medication all day. So instead of you not going in another 2 hours asking for pain medication, in your mind, you're going to say or think that, oh, well, they'll ask me for pain meds when they want them. Well, you may not assess the patient for another 8 hours. So that makes it now 10 hours that your patient had anything for pain. And when you go in at that 10-hour mark, or it'll be 8-hour mark for you, their pain is now at an 8. So you see where that break in communication and that pain threshold can just go out of the window. This is why they're recommending that around the clock scheduling. So your book does define it. ATC regimens are designed to control pain for patients who report pain being present 12 hours or more during a 24-hour period. PRN dosing analgesic agents is appropriate for intermittent pain, such as prior to painful procedures and for your breakthrough pain. Patients with persistent pain in the hospital setting should be awakened to take their pain medications. Awakening post-operative patients with moderate to severe pain to take their pain medication is especially important during the 24 to 48-hour period right after surgery to keep the pain under control. Patients should be told that this helps to avoid waking up with severe pain, and that if their pain is well controlled, they are likely to go back to sleep quickly. The patient can transition gradually to the PRN dosing as the pain evolves. So you want to make sure, especially if your patient is... So when we look at opioid tolerance and addiction a little more in depth, we want to look at and define our dependence versus tolerance versus what is actually considered addiction. So first of all, unless there is strong evidence that your patient is really not in pain, we really have to go with the word of the patient. Whatever they say their pain is, it's what we have to go with. So when we look at dependence, the terms physical dependence and tolerance are often confused with addiction. Thus, clarification of the definitions are very important. Looking at physical dependence, this is a normal response that occurs with repeated administration of opioids for 2 or more weeks and cannot be equated with addictive disease. It is manifested by the occurrence of withdrawal symptoms when the opioid is suddenly stopped or rapidly reduced, or an antagonist such as naloxone, which is also your Narcan, that is given. Withdrawal symptoms may be suppressed by the natural gradual reduction of the opioid as pain decreases, or by gradual systemic reduction referred to as tapering. So, if your patients are going home on, let's say, Percocet, that's a well-known drug that people go home on. If they're on Percocet for, let's say, 2 or 3 months, and they've been taking that for their hip replacement that they got, well, then they may be dependent on it. And so when they're going back for their checkup in that first month post-operatively, the doctor may ask, how's your pain doing? How many Percocet are you taking a day? How many are you taking a week? Let's go ahead and taper off of those. They won't ever tell you to just completely stop. They will tell you, let's taper off of those. So if you're taking two a day, and that's hardly anything. So let's increase that. Let's say you're taking 6 a day. That would be That would be pretty good if you're taking them every 4 to 6 hours. That would be fine. So let's say you're taking 6 a day. The doctor will give you a regimen on how to taper off of those. He may say, let's move that dose down to now 4 a day, and with skip that middle dose and take 8 Motrin instead. And then, do that for a week, and that next week's go down to taking 2 Motrin a day and 1 dose of the Percocet. And so they will taper you off of them slowly so that your body doesn't jolt into a withdrawal. So when we look at tolerance, this is also a normal response that occurs with regular administration of an opioid and consists of a decrease in one or more effects of the opioid. It cannot be equated with addictive disease either. Tolerance to analgesia usually occurs in the first days to 2 weeks of the opioid therapy, but is uncommon after that. It may be treated with increases in dose. However, disease progression, not tolerance to analgesia, appears to be the reason for most dose escalations. Stable pain usually results in stable opioid doses. So what is meant by that is if you have a disease process that is getting worse instead of getting better, hence why your pain is getting worse, and hence why you would need more analgesia than less. If your body's healing, your opioid analgesia doses should remain the same or even decrease as the days go forward. Now, when we look at opioid addiction or addictive disease, this is a chronic neurologic and biologic disease. The development and characteristics of addiction are influenced by genetic, psychosocial, and environmental factors. There's no single cause of addiction, such as taking an opioid for pain relief, has been found. It is characterized by behaviors that include one or more of the following: impaired control over drug use, compulsive use, continued use despite harm, and craving to use the opioid for effects other than pain relief. Pseudo-addiction is a mistaken diagnosis of addictive disease. When a patient's pain is not well controlled, the patient may begin to manifest symptoms suggestive of addictive disease. In an effort to obtain adequate pain relief, the patient may respond with demanding behavior, escalating demands for more or different medications, and repeated requests for opioids on time or before the prescribed interval between doses has elapsed. Pain relief typically eliminates these behaviors and is often accomplished by increasing opioid doses or decreasing intervals between the dose. The incidence of addiction as a result of taking an opioid for therapeutic reasons is thought to be quite rare. One other thing I want to look at when we look at opioid tolerance and addiction is whether the patient is opioid naive or has an opioid tolerance. Whereas an opioid naive individual has not recently taken enough opioid on a regular basis to become tolerant to the effects of an opioid, an Looking at the gerontologic considerations, note that older adults are often sensitive to the effects of adjuvant analgesic agents that produce sedation and other CNS effects such as antidepressants and anticonvulsants. Older adults are at an increased risk for NSAID-induced GI toxicity. Acetaminophen should be used for mild pain only. It is recommended as first line for musculoskeletal pain, such as your osteoarthritis in older adults, but is less effective than the NSAIDs for chronic inflammatory pain, such as your rheumatoid arthritis. The addition of a proton pump inhibitor to an NSAID therapy or opioid analgesic agent rather than an NSAID is recommended for your high-risk patients. Age is considered an important factor to consider when selecting an opioid dose. The starting dose should be reduced by 25 to 50% in adults older than 70 years of age because they are more sensitive to opioid adverse effects than the younger adult. The amount of subsequent doses is based on the patient's response. So, it is just like other drugs. You want to start low and go slow. That will be your theme for the gerontologic population. Whereas let's say you would give your 20-year-old patient 5 milligrams of Percocet or 5 milligrams of oxycodone and 325 milligrams of Tylenol, which would be your Percocet. That would be equivalent to one Percocet. For your elderly population, let's say you're 75-year-old, you may only give 2.5 of oxycodone and 150 of Tylenol. So that's like half a Percocet. So usually they reduce those drug amounts when it comes to your gerontologic population. Now let's look at some non-pharmacological interventions. Most individuals use self-management strategies to deal with their health issues and promote well-being. Non-pharmacologic interventions are categorized as being body-based, which are your physical modalities, mind-body-based, which are your cognitive behavioral methods, and biologically based therapies, as well as your energy therapies. Your text 232, there is a table 12-5 that gives you a brief list of your non-pharmacologic methods. The one that I do want you guys to look more closely at is your mind, body, or your cognitive behavioral methods. These are the ones that you see more frequently used within your healthcare facility, mostly being your music, imagery, meditation. They even have pet therapy, and of course, prayer and singing. Non-pharmacologic methods are usually effective alone for mild to some moderate intensity pain, and they should complement but not replace pharmacologic therapies for more severe pain. So this is really saying that although your patient may be involved with meditation, this may only go so far. So don't just tell your patient to meditate the whole time if their pain is an 8 out of 10. They may need some medication because they're nearing that severe point of pain. Now, as we can play an important role in providing them as far as the non-pharmacologic methods go and instructing the patients on how they are used. Like I said, there are several that are used within healthcare setting, and they seem to provide comfort and pain relief for all types of pain. However, time is often limited in this setting for implementation of those methods. Also, chart 12-7 in your text goes over some considerations in selecting and using those non-pharmacologic methods. They may not be suitable for everyone. Here are some more non-pharmacologic interventions. We went over those. Your guided imagery, hypnosis, your music therapy, those are all used within your mind, body, or those cognitive behavioral methods. Those are the ones that you'll see more often within the hospital settings. Now, when we look at pain relief interventions and we go over that pharmacologic basis, this will actually go back in your text starting on page 222. First, we'll look at the patient-controlled analgesia, and that's also known as a PCA. This is an interactive method of pain management that allows patients to treat their pain by self-administering doses of analgesic agents. It is used to manage all types of pain by multiple routes of administration, including oral, IV, subcutaneous, epidural, and perineural. A PCA infusion device is programmed so that the patient can press a button to self-administer a dose of an analgesic agent at a set time interval as needed. Patients who use PCAs must be able to understand the relationship between pain, pushing the PCA button, or taking the analgesic agent and pain relief, and must be cognitively and physically able to use any equipment that is utilized to administer the therapy. The use of a basal rate is common when the PCEA is used, and it is often added for the patients who are opioid tolerant and sometimes for patients who are opioid naive and receiving IV PCA to allow them to manage their pain and rest a little better. However, it is important to recognize that patient has no control over the delivery of the continuous infusion. Therefore, extreme caution in using basal rate for acute management of an opioid naive individual is recommended. The primary benefit of PCA is that it recognizes that only the patient can feel the pain and only the patient knows how much analgesic will relieve it. This reinforces that PCA is for the patient use only and that unauthorized activation of the PCA button should be. So when we talk about PCAs, we have to educate when it comes to the patient and their family members. You want to first note that family members are not supposed to be touching that button, that the patient is the only one who can press the button. Make sure you educate the patients on how often they can press the button as well. Most PCAs are programmed where you can press the button or the patient can press the button every 6, 8, or 10 minutes. It will give them a small, minute dose of whatever medication is in the vial or the syringe. It can be anything from fentanyl, morphine, hydromorphone, which is your Dilaudid, and they usually get like 0.2 milligrams every 6 to 8 minutes. There is a lockout rate also, usually of like 1 milligram or 1 milligrams per hour, so that they're not getting like 3 and 4 and 5 milligrams an hour and they're zonked out. So you, as the nurse, will check the PCA with another nurse, especially if you're the one initiating it. Of course, you have to have the order pulled up. 2 nurses have to check it and before you start it. And usually the patient will get a low bolus dose as well. Now, if you are giving that loading bolus dose, please make sure that you are assessing for some adverse effects, which we will talk about in a few seconds. But I want to go over the rest of these pharmacologic therapies, and we will talk a little bit more about what to look for when we're assessing for those adverse effects with that medication. While we're also talking about a PCA, I want you to know that we are checking that patient more often than not, especially for vital signs and things of that nature. And we still have to check the patient's pain level, even though they have their own pain control. We still have to assess that fifth vital sign of pain, so do not forget that. Also note that if conventional pain management doesn't work, the healthcare provider may look to that intracathecal or an epidural catheter for pain relief. So they may look for that epidural if, let's say, your PO hasn't worked, the IV hasn't worked, they may go to an epidural route. So also looking at those analgesic agents, those are categorized into three main groups. You have your non-opioid analgesics, which include your acetaminophen, your NSAIDs. You have your opioid analgesics, which include things like your morphine, hydromorphone, fentanyl, and oxycodone. And then you have your adjuvant analgesic agents, which are sometimes referred to as your co-analgesic agents. These comprise the largest group and include various agents that are unique and widely different mechanisms of action. So first we'll look at your non-opioid analgesic agents. That includes your acetaminophen and your NSAIDs. Make sure you know the dosing for these. We can only give so many grams of each. So each hospital policy is different, especially if you're giving, let's say, Percocet that includes acetaminophen. So you don't want to give your patient acetaminophen and then give them Percocet. We do not want to overdose them or have them with liver toxicity. So your non-opioids are flexible analgesic agents for a wide variety of painful conditions. They are appropriate alone for mild or some moderate nociceptive pain, and are added to opioids, local anesthetics, and or anticonvulsants as a part of a multimodal analgesic regimen for more severe nociceptive pain. They may be given concomitantly, and there is no need for staggered doses. Unless contraindicated, all surgical patients should routinely be given acetaminophen and an NSAID in scheduled doses throughout the postoperative period. They are often combined in a single tablet with opioids, such as your oxycodone, that's your Percocet, or your hydrocodone, which is your Vicodin or Loratab. And those are a very popular treatment for your mild to moderate acute pain. Acetaminophen, it is versatile and can be given in multiple routes of administration, including oral, rectal, and IV. Your oral has a long history of safety and recommended doses for all ages. Your IV, which is your Ofirmev, that is given more frequently now, especially for your post-operative patients. It is approved for treatment of pain and fever, and that is given over 15 minutes. It also comes in a glass vial. So, and you have to have tinted tubing as well to hang that. So, it is unique to see it. A benefit of the NSAID group is the availability of the wide variety of agents for administration via non-invasive route. Your ibuprofen, your naproxen, those are your most widely used in the U.S. Your IV formulations, which is your Toradol or Caldolor, are available for acute pain treatment as well. Usually they have Toradol for your breakthrough pain, when your patient is on IV medications. So they may have like IV morphine, and then for pain, then they'll have like ketorolac or the Toradol for breakthrough pain. Both have been shown to produce excellent analgesia alone or for moderate nociceptive pain and significant opioid dose-sparing effects when administered as a part of that multimodal analgesic plan for more severe nociceptive pain. Now, when we look at the adverse effects of analgesic agents, the most important thing you can check for is respiratory depression. And that's what I was going to say when we were talking about your PCAs and your patients getting too much of it. You want to check for that respiratory depression. That is so, so, so important. Especially if your patient is receiving a loading dose. That gives them I wouldn't say a large amount of medication, but it does give them a pretty good amount to start off with. So if let's say morphine, they may get like 2.5 milligrams or 3 milligrams of morphine as a loading dose on top of them being able to push their button every 6 minutes. So you do not want, they lock it out so that the patient can't overdose, but the patient can press that button like every 6 minutes, especially those that are opioid tolerant, till they get enough medication, and then there's like out like a light, and you're thinking they are fine and they are not in any pain when really they're like almost in a coma. So if you go in and you see your patient is like very shallow breathing, anything less than 12, we're concerned about. And if your patient is not easily aroused, or you can tap them and wake them up, then we have to do that sternal rub, and I can really show how that's done within class. It is very interesting, and if you've ever had it done, you will never want it done again. So that is one thing that you can do to awaken your patients. Also, that goes into sedation. They can go into that sedation. You may have those unconscious sedation, but that's more so for your procedures. Once they come back to you, especially if they're on a med surg, they should be awake. They may be sleepy or in and out of sleep, especially that first day or so after after a surgery or a surgical procedure. So you just want to check their level of consciousness when you're doing that. Nausea and vomiting is always part of any analgesic agent. That can be an adverse effect. When you're getting these analgesic agents, especially your opioids, these can cause constipation, especially if you're taking them quite often. So the healthcare provider will usually provide the patient with a stool softener and some kind of help agent like your milk of magnesia, or even laxative if your patient is unable to go to the bathroom. And then itching may be an adverse effect as well. So these are things that we look for, and usually if this is their first time taking it, and then like 30 to 45 minutes later they're saying they're itching, that may be an adverse effect of the medication. Now, if they're able to take Benadryl with that medication and they're fine, then usually they'll say they'll want it. But you have some people that say they start itching and they don't want it at all after that. So please make sure you're reassessing your patients after you give them any type of pain medication. When we look at the acetaminophen and NSAIDs, your acetaminophen is widely considered one of the most safest and best tolerated analgesic agents. Its most serious complication is your hepatotoxicity, or your liver damage as a result of an overdose. So in a healthy adult, the maximum daily dose below 4 milligrams, 4,000 milligrams, 4 grams is the most for the day. This is rarely associated with that liver toxicity. This is why I said make sure you're not giving your patient regular Tylenol, because your physicians may have standing orders that say you can give extra strength Tylenol 1,000 milligrams, but then they also have 2 Percocet every 6 hours that are ordered. So do not give your patient 1,000 milligrams of Tylenol and then give them Percocet, 4 hours later. You're gonna reach that threshold or that maximum dose within your 24 hours very quickly. So we as nurses have to be vigilant of that as well. Nonetheless, one manufacturer of oral acetaminophen voluntarily changed its dosing recommendations in 2011, calling for a maximum daily dosage of 3,000 grams or 3 grams a day. So you want to look at the hospital's policy and procedure, and usually the pharmacy actually has it built into their programs, their EMARs, that'll let you know if the patient can have 4,000 grams a day or 3,000 grams a day, and it'll let you know when you're nearing that max as well. For your NSAIDs, they have considerably more adverse effects than acetaminophen, with the gastric toxicity and ulceration being the most common. Most non-selective NSAIDs increase bleeding time, so you want to keep an eye on that as well. And all NSAIDs carry a risk of CV adverse effects through prostaglandin inhibition, and the risk is increased with COX-2 inhibition, whether it is produced by the COX-2 selective NSAID or by NSAIDs that are non-selective inhibitors of both COX-1 and COX-2, which are your, ibuprofen, your ketorolac, and things of that nature. So you do want to pay attention to that as well when you're giving both acetaminophen and your ibuprofens. As for your opioid analgesic agents, safe and effective use of the opioid analgesic agent requires the development of an individualized treatment plan, clarifying the goals and treatment, and discussing the options with the patient and the family. Usually, titration of the opioid dosage required at the start and throughout the course of the treatment when opioids are administered. Whereas patients with cancer pain most often are titrated upward over time. For progressive pain, patients with acute pain, particularly postoperative pain, are eventually titrated downward as the pain resolves. So, cancer patients are like your unique patient population. So, whereas your postoperative patient that, let's say, may have had a hip replacement, we're going to titrate down off that fentanyl. For your cancer patient, you may be titrating upward when we're giving that oxycodone. So it just all depends on your patient population. I do want you to look at chart -4, which goes over the use of opioids. And then here we look at the nursing process framework for pain management. Of course, you want to identify those goals for pain management. Make sure you're talking to your patient and their family members, finding out what it is, the goal they actually want to achieve when they look at that pain management. Establish that nurse-patient relationship. You're going to be educating these patients. Your planning starts from the time they're admitted. You want to provide that physical care, manage any anxiety that's related to pain, and of course you want to evaluate those pain strategies. And one more thing before we end out the chapter with pain management, just make sure you know those most common opioid analgesics are your hydromorphone, oxycodone, your hydrocodone, but the standard is morphine, and it just all depends. The gold standard is morphine, but it just all depends on your healthcare provider's preference and what they actually want to use. Um, they've moved away from using Demerol in the hospitals. Some still use it for shivering, but they've moved away from using it for pain. Darvocet. So it's some that have been taken off that you may have been used to hearing about. Your Tylenol number threes, they're less effective and they're associated with more adverse effects. Of course, your post-operative nausea, vomiting. Those are your most unpleasant adverse effects that you will see. So you want to make sure you're educating your patients about that. Also, you want to educate the family members about pain management and monitoring their family members that are in the healthcare facility, because if they're going to be staying with the patient, they need to know, the patient's level of consciousness. If the patient, breathing is decreased, they too can help us as healthcare providers look for that. So, as nurses, we should promptly reduce opioid doses or stop titration whenever advancing sedation is detected to prevent respiratory depression. We really, really, really want to prevent respiratory depression. So we want to look for that level of consciousness, and they experience sedation, at the beginning when we start that opioid analgesic. So we want to look and assess that sedation level, that level of consciousness, and that respiratory depression. I cannot stress that enough. Also, for your patients that are going through surgical procedures and they may have limbs removed, like may have a leg removed, they may have a foot removed, if they're still feeling pain afterwards, please let them know that this is normal. It's also known as phantom pain. Educate the patient that what it is the abnormal reorganization of the nervous system, which is talked about in that neuropathic pain response. So you do want to educate them, but break it down in terms that they would understand. And here's a question in regards to post-operative pain, post-operative orders for your opioid analgesics. And here's the answer with the rationale. And before we conclude Chapter 12, I just want you guys to briefly review local anesthetics and your anticonvulsant and antidepressants. These three are found in your text on page 231. Just review what they are, what they're used for, and with that said, that will conclude Chapter 12, which covers pain management.